Hello, I'm one of the hospitalists here at Stratford. My name is Amit. I've been working here for about 3 years. So I'm doing a presentation on cancer screening. The reason why it's important that we screen for cancer is because 1 out of 3 cancer deaths could be prevented by early detection. So it's important that all our patients stay up to date on all their screening for the certain type of cancers that we screen for. So the younger people probably see these hashtags somewhere on their online stuff, cancer sucks, and the other one. Just put that in. So this is a graph from Canada.ca. So these are the leading causes of cancer deaths, leading causes of deaths in Canada. And you can see by a good number, malignant neoplasms by far is a leading cause of deaths in Canada, followed by heart disease, strokes, and then accidents come in 5th. And you can see right at the bottom, I don't know if you guys can read that small, but suicides are in the top charts as well. So a lot of these things are fairly commonly managed in the outpatient clinic, including mental.
What's the top one?
Malignant neoplasms, so cancer.
Okay.
Yeah.
I
So
can't read it from.
Yeah, I know, I'm sorry, it's pretty small, but it's about 30%. And then if you look at the number of cancer deaths by age group, so as you can see, as ages go up, so this is less than 30, 30 to 39, 40 to 49. So the 2 biggest ones are 70 to 79 and 80 to 89. So those are the ages that most of the deaths related to cancer happen. The reason why, so there's a strong drop after 90 because a lot of the slow-growing cancers, such as prostatic cancer, patients die from causes other than the prostate cancer. So most of the cancers are diagnosed between 70 to 90, and the deaths usually occur around then as well. So you guys probably can't see this as well. So 5 of the most common cancers in males. So number 1 is prostate cancer, lung and bronchus cancer, colorectal cancer, bladder cancer, and then non-Hodgkin's lymphoma. So prostate cancer is the leading, one of the most common causes of cancer in males, but it's one of the slowest growing cancers. So as I said, most people don't die from prostatic cancer, but rather other comorbidities. And then 5 of the most common cancers in females. So by far, breast cancer is the most common. Then lung cancer, colorectal cancer, uterine cancer, and thyroid cancer. So as you can see from these 2 lists, the reason why we screen for breast, prostate, lung, and colorectal cancer is because they're the leading causes of, or they're most common causes of death related to cancer in males and females. So I'm going to start off by talking about how we can prevent cancer. I think that's probably the most important because in the outpatient family medicine practices, we should be educating our patients on how to stay healthy and doing everything we can to prevent cancer. So obviously not smoking, not drinking alcohol, stay away from drugs, exercise, eat healthy, well-balanced diets. So vaccines are pretty important as well. So against hepatitis B and HPV. So HPV is a risk factor for cervical and uterine cancer. And hepatitis B can cause liver cancer as well. Tanning beds for skin cancer. And effective ways to cope with stress is another important point that we need to teach our patients.
Can I ask a question?
Sure.
I know that my neighbor's kids got vaccinated in school for, I think, HPV and Hep B. Is that correct?
Yep.
Yeah, but when I was in school, we didn't get those vaccines. Does that mean that I have to go now and get a vaccine like that?
No. So the HPVs are usually up until 24, and sometimes we give it to higher risk people after the age of 24. So so I don't know your age, but we generally start screening for cervical cancer at the age of 25 to 30 now. We add HPV after 30. But the risks as we get older become less related to HPV. Sorry.
As it gets older, the risk is less?
Yeah.
Let's say I'm
Related to
60
HPV.
now.
Yeah.
So do I need to get vaccinated for any of those?
So hepatitis B, yes, especially if you're traveling. And then you want to check your titers just to make sure that you are immunized. So hepatitis B is recommended that you do stay up to date. Hepatitis or HPV, the recommendations are under 24.
Okay.
Okay, but that also, at the age of 60, you should continue getting screened with pap smears, and then all your other screening tests. So we
Yeah.
generally don't screen for hepatitis.
Is there
Or liver
another
cancer.
hep test, hep A maybe?
Hep test?
Yeah?
Yeah, so we can test for hepatitis A, but that's usually done if there's concerns for hepatitis A. So
Okay.
diarrhea, recent travel, elevated LFTs, cirrhosis, or whatever the case is.
Because I think as a volunteer, we get those shots here, vaccines,
Yep.
in the hospital. So,
Yeah, so we should, especially if we're working in healthcare, we should stay up to date with our immunizations.
every
Because
how
we're-
long you need to have those?
So usually they last about 10 years.
Okay.
But like I said, if you're questioning if you have immunity to them, you can always get the titers done.
Titers?
Yeah. So it's a blood test and it checks your immunity status.
Thank you.
Any other questions? No. So anyway, this is probably the most important slide because as healthcare professionals, we should really stress on preventative medicine. So how are cancer screening guidelines developed? So what we do in basic terms is we look at all these tests and we look at the risks and the benefits. Because with every test comes risks and further testing that can cause more problems. So for example, if we look at the PSA is not recommended for prostate cancer, depending on who you ask. In the States, where I was trained, the American College of Urology recommends PSA testing, but I think they're probably the only group that recommends it. So the PSA can be elevated for multiple reasons. It could be elevated from infections to urination, multiple reasons. So what happens if the PSA is elevated, it can trigger a series of tests such as ultrasound, so that could be fairly invasive, and biopsies, and further testing that put the patient at risk for infections and other things. So we always weigh the risks and the benefits. We see how many false positives and negatives can come out of these tests. And there's no test that actually is perfect for screening other than the diagnostic tests. So we'll start off with breast cancer, one of the most common causes of cancer, or cancer in women. So the Canadian Task Force for Preventative Health, they released some guidelines in 2011, and as you can see, a lot of them are weak recommendations. The reason why is because mammograms can, again, lead to biopsies and further testing, which can be unnecessary. So in 2011, they said women aged 40 to 49, you do not screen. And sorry, this is for a healthy female who does not have any risk for breast cancer. So if the BRCA genes are all negative, which we generally don't check unless there is a strong family history. So for ages 40 and 49, we do not treat or test. 50 to 69, mammograms every 2 to 3 years. And then 70 to 74, again, mammograms every 2 years. And then they came out with some revised statements. So pretty much they're saying they recognize that mammograms can lead to unnecessary biopsies and lumpectomies, which put the patient at risk. So now they're saying, from ages 40 to 49, you want to discuss with your family doctor the risks and the benefits, and if you have a family history and concerns of cancer, it's reasonable to check. as long as we understand the potential need for further testing. And then same thing for ages 50 to 74. Again, you want to have that conversation with your doctor. So these are not concrete, every patient needs screening anymore. So this is a new release in 2018, so last year.
Why do they stop at 74? And would it make a difference if your sister had breast cancer?
So they look at the rates of cancers per age group, and then they say, after the age of 70, the rates of cancer go down. So if we continue to screen, we're screening a lot of unnecessary people. So, and again, this is for the healthy person who does not have any risk factors for cancer. Any other questions? Yeah.
For a person who has had a mastectomy, what is the incidence of getting cancer in the other breast?
So I think that's a question you need to ask the oncologist. This presentation is pretty much screening. So yeah, I'm not familiar with the rates of reoccurrences and all that. Yeah. Any other questions? So, and then they release some statements. They do not recommend MRIs, tomosynthesis, or ultrasounds to screen for breast cancer. They're not effective in screening. And then they also do not recommend self or clinical breast exams. In outpatient clinics, I see a lot of patients that come to us after they felt a breast mass, and we order ultrasounds, and especially for the younger females, they're fibroadenomas. So self-exams and clinical breast exams are not indicated due to the potential risk of further testing, unnecessary further testing. Any questions? Yeah.
In cancer prevention, I know some people that have had history of breast cancer in the family, so it differs whether it's on the mother's side or on the father's side. And then some of them say, if I am at a high risk, why don't I go and have my breasts removed? Is that a good way of prevention?
So again, that's another question for the oncologist. This is for screening, but if you're high risk with positive BRCAs, then that's a conversation that you may want to have with your family doctor, because if there's first-degree relatives with a positive BRCA, that person would be at higher risk. And sometimes the surgeons do agree to do double mastectomies.
I have had a friend whose two sisters died with breast cancer, and she did have both breasts removed.
Yep.
Was tested, her 3 children, 2 out of the 3 had the same gene.
Yeah. Yeah, so the BRCA gene puts you at higher risk for cancer. So, and that's not routinely done. You have to have documented. It's a fairly long process to get that test done as well. So risks of mammograms, radiation exposure, they're not always accurate. They can be difficult to interpret in young females just due to the density of the breast. And again, may lead to additional testing such as biopsies and lumpectomies, and also cannot detect all types of cancer. And if it's found too late, all tumors cannot be cured.
Sorry.
Yeah.
Sorry, I'm asking a lot of questions.
Not a problem.
It's, I had cancer in my family, that's why I'm asking. In the breast cancer, there are several kinds of cancer in the breast cancer? Or it's only one cancer that attacks breast?
So there's different types of cancers, and then there's cancers that spread as well. So there's different genes as well that we have to look at. The 2 common ones are the BRCA1 and 2s, but there are different genes.
Also, they could be in other areas of the body and then spread to the breast?
Yes, sometimes they can. So like melanomas, I've seen.
What did you say, bracket?
BRCA, B-R-C-A, 1 and 2.
Bracket, okay, thank you.
So mammogram, essentially it's just an x-ray where they put the breast between 2 plates and get a picture. Okay, cervical cancer. Any questions regarding cervical cancer before we start?
I can ask another question.
Sure,
You're gonna hate me at the end.
that's okay.
Till what age should women have cervical cancer checked?
Yeah, so we're going to get to that.
Okay.
Yeah, so these are the guidelines for screening. So cervical cancer also is one of the more common cancers in females. And again, so these guidelines are for the healthy female who have been sexually active, and they do not apply to women with cervical cancer, previous abnormal Pap tests, because if there's previous abnormal Pap tests, then there's a different testing strategy that we do. And then people who do not have a cervix. So this is particular just for the healthy female who does not have any risk factors that is sexually active. And it came out in 2013. So for cervical cancer, I feel like in my short time of practice, I've seen so many different new guidelines, especially within the States and Canada. Initially, when I started going to med school, the recommendations were to start screening 3 years after a patient was sexually active. But then we've realized that even though or females can have abnormal cells, most of them do not cause cancer until a later age. So now they realized we're screening all these females having abnormal results, causing a lot of anxiety, but the end result, it did not lead to cancer and the cells just normalized. So in 2013, we came up with some new guidelines saying females under the age of 20 should not be routinely screened. And then 20 to 24, again, we do not routinely screen. So when I was in my residency a little while back in the States, we would start screening everybody at the age of 21. So the US and Canada, unless they've changed their guidelines, we've had different guidelines. And then from ages 25 to 29, we recommend routine screening every 3 years. Okay? And then from 30 to 69, we do screening every 3 years combined with HPV testing. Okay, so those are just 2 samples of the cells from the cervix. And then for ages 70 and greater who have been adequately screened, we recommend that we stop do Pap smears. So that answers your question.
At age 70?
Yeah. Okay, but if somebody has not had routine testing, we would recommend you continue doing it for another 3 negative tests. So again, so the risks, it's not foolproof. Risk for false negatives, because you have to get some of the sample of the cells from the cervix, and it's easy to miss them. If you have a small number of abnormal cells, if you don't swipe the cervix properly, and then blood or inflammatory cells can obstruct getting a proper sample as well. So the procedure, insert a speculum, and we get a sample of cells from the cervix. Any questions? Colorectal cancer. So this is one of the common cancers in males and females. So this recommendation applies to males and females over the age of 50 who are not at high risk for colorectal cancer. So this does not apply to people who've had previous cancers, polyps, inflammatory bowel diseases such as Crohn's or ulcerative colitis, or any of the other risk factors. Okay, so this is for the healthy person without polyps or higher risk of colon cancer.
Does colorectal cancer have any symptoms?
Absolutely.
Which are what?
So it could be abdominal pain, blood in the stool, diarrhea, weight loss. But the biggest concern as a family doctor, as an outpatient, if you have blood mixed in your stool, we need to check for colon cancer. Okay, so there's different types of blood in the stool. So if it's bright red blood on the outside of the stool, it's usually from a lower source. So hemorrhoids, fissures, constipation. But if it's black tarry melena type of stools, we need to generally get a colonoscopy.
So the test for it is colonoscopy.
So I'll get to that in a second.
Okay.
Yeah,
I'm competing with you.
yeah, that's fine. You're getting all your questions answered. So initially it was colonoscopies, but they've changed the guidelines as well.
Because I have a cousin who died of colorectal cancer. When he realized he had it, it was stage 4.
Yep.
And when he realized it, went to the hospital, he was gone 6 days after.
So was he screened previously?
No, he thought he's healthy.
Yeah. So the reason why we have different intervals, time intervals between screening tests is because we look at how quickly the cancer grows, right? So colon cancer doesn't grow as fast as pancreatic cancer or as slow as prostatic cancer. Breast cancer is a little bit quicker. So we say, if you get screened by sigmoidoscopy, in 2020, the next screening test would be within 10 years or so, because colon cancer doesn't grow that fast and it doesn't metastasize as quickly, right? Whereas breast cancer, it's a lot quicker growing, so we screen every couple of years. So the recommendations are, we recommend screening adults aged 60 to 74 with FOBTs, so fecal blood tests. So this is just a stool sample that we check for blood. And remember I said if there's blood mixed in the stool, that's an indication to get checked. So that happens every 2 years, or we do a flexible sigmoidoscopy every 10 years. So it checks for the lower source. Okay, so either or. And then we recommend screening adults 50 to 59, again with the same methods, FOBT every 2 years, and a flex sig every 10 years. And then we do not screen after the age of 75, because after the age of 75, the incidence of colorectal cancer steeply declines. So if you guys remember the slide at the beginning, age 90, the deaths from cancers, they decrease significantly. And then we recommend not using a colonoscopy for a screening test for colorectal cancer. So they've changed that guideline. Good? Any questions? So the risks for FOBT, you have to get a good sample. Sometimes you can miss some blood. And again, it could lead to other tests. Because if you have bleeding from anything else that is not colorectal cancer, it may lead to other tests such as colonoscopies, which can be fairly invasive. So FOBT procedure, you just get 2 or 3 samples of stool, put on a card, and you give it back to your doctor or life labs. And the flex sig, the risks, it's a procedure, it's an invasive procedure. You can have bleeding, infection, because if you take a biopsy, the area can get infected. And one of the worst risks are bowel perforation, where the scope tears part of the colon. Questions? Okay. So there's a prep involved with the scopes. So you can't eat, you do laxatives or enemas to clean up the bowel, so the surgeon can have a better look at the colon. And then you may have to stop some of your medications, such as diabetes, iron, blood thinners, because if you're not eating, your sugars can go low. Blood thinners, if we're going to get a biopsy, you want the bleeding to stop as well. So it's a little bit more involved in a sigmoidoscopy. So the procedure, essentially, they stick a scope in the backside, fill it up with air, and they look for any abnormalities inside the colon. And if there's polyps or anything like that, they'll biopsy it. If there's any abnormalities, they'll take pictures and biopsy it as well. Usually takes about 15 minutes. Questions? No. So lung cancer, there's always been a debate regarding lung cancer screening. So all the newer recommendations recommend screening for adults aged 18 and older who are healthy, but who do have a smoking history. Okay, so the recommendations are for ages 50 to 74 with at least a 30-pack year smoking history. Okay, who currently smokes or quit less than 15 years ago. Okay, and the screening would be low-dose CT scans up to 3 consecutive times. So they haven't released, because this is fairly new, they haven't said, you know, every 2 years or whatever the case is. They just say if anybody has smoked 30 packs a year at some point in their life, they should get checked for or screened for lung cancer. Chest X-ray and sputum cytology is not recommended. Chest X-rays are not good at finding cancers. And then sputum cytology, again, you have to get a very good sample, so there could be a lot of false negatives. And then risks for low-dose CT, radiation, again, undergoing follow-up tests, which can be bronchoscopies, biopsies, and all that. And then finding cancer that's too advanced. So sometimes it's better to not know if you not know how bad the cancer is. You can miss cancers, and you can find other health problems when you scan the chest. And again, it's just it's like getting a CT scan. So, prostate cancer, leading cancer in males, one of the most slow-growing cancers. We see a lot in the hospital. Again, this guideline applies to all men who have not previously been diagnosed with prostatic cancer. So this includes men with lower urinary tract symptoms. So anytime a male comes in with hesitancy or urgency or any symptoms that can mimic prostate cancer, you always have to send off urine cultures to make sure it's make sure it's not something other than prostatic cancer. So the recommendations are for men aged less than 55 years old. We do not recommend screening with a PSA. So the PSA, again, there's a lot of discussion about it, but the Canadian Task Force recommends against using it. Same with the USPSTF, so the American Task Force for Preventative Medicine. They all recommend that we should not be using the PSA for screening. And they actually don't have any recommendations for the digital rectal exams. So that's pretty much a guideline. So it's kind of interesting, there's no guidelines to actually screen for prostatic cancer. So it's symptom-based. And the reason why is, like I said, it's one of the slower-growing cancers, so even if it's picked up, most people do not die from prostatic cancer.
What are the symptoms of prostate cancer?
So you can have urgency, hesitancy, dribbling, so any type of urinary issue, pelvic pain, blood in the urine.
What about enlarged prostate?
Yeah, so that would not be a symptom, right? So that would be a finding, right? So a symptom is what we feel, and a finding, yeah, so if you do a digital rectal exam or an ultrasound, you would see an enlarged, irregular prostate.
That wouldn't be enlarged for any other reason other than cancer?
So it could be enlarged for any other reason, right? So as I said before, if somebody's having any urinary symptoms, you need to check to make sure it's not only cancer. It could be infection, prostatitis, it could be numerous things, right? And then the Canadian Task Force is coming up with guidelines for esophageal adenocarcinomas. Again, not common. They have plans to release these guidelines this year, apparently. And these are my sources, Canadian Task Force for Preventative Healthcare, Canada.ca, and Mayo Clinic.
Sorry if I won't bother you with
Not at all.
question, but I don't have an opportunity to ask someone like you every
Absolutely.
day.
Yeah. Oh, that's fine. Do you have any more questions?
No.
Okay. Yeah, sure.
What is the causes mainly of multiple myeloma?
Multiple myeloma.
Yes.
So it's a cancer in the blood,
Right.
and it usually affects the bones.
Pardon?
It usually affects the bones.
The bone.
Yeah. So usually,
And the life expectancy once they are diagnosed?
so it depends. Once somebody's diagnosed, it depends when they're diagnosed along the cancer, right? So usually, when symptoms start occurring, it's close to being a little bit more advanced, right? So we do not screen for multiple myeloma, but usually when it is diagnosed, it has spread to certain areas, such as a bone.
Right?
Yeah.
Because she's 78 when it was diagnosed. She's 80 now, so she's about 2 years.
Yeah, and again, a lot of people survive from multiple myeloma as well for
Do
years.
they?
Yeah.
Wonderful, thank you.
But again, it's at what point have they been diagnosed? That's the main. So other cancers like pancreatic cancer, again, we don't screen, and usually by the time they're diagnosed, it's such a fast-growing cancer, their 5-year survival rate is not high.
Any other questions for Dr. Kroll?
Yeah.
I just had one. I just wanted to ask, is the rate of the prostate cancer, the death rate being higher because of like a reluctance to go get tested? Like, I don't know, like if it's because of...
So the death rates are not as high.
Not high,
Yeah.
okay. but-
Because it's a slow-growing cancer, and it doesn't metastasize as quick. So the cells in the prostate the characteristics, they don't spread as quickly.
But it's the highest rate of...
It's the most common
Okay.
cancer in males, but the least amount of deaths.
Okay, perfect.
Any other questions? No? Well, thank you very much, Dr. Kroll. We appreciate that.